A very good afternoon, everybody, and a warm welcome to the 13th webinar in the series of Patient Support Group of IS BMT webinars. And this one is a special one for all the pediatric hemato-oncologists across the country, for all the children who have struggled with cancer or who are struggling, the families who are involved, the caregivers who are involved, because September is Childhood Cancer Awareness Month. And so, for this month, we have chosen the topic as indications for bone marrow transplant in children with ALL, that is acute lymphoblastic leukemia, because ALL is the most common cancer seen in children. So September, as I said, is observed as Childhood Cancer Awareness Month across the world in order to raise awareness about childhood cancers, in order to honor our little warriors and their caregivers. And the golden color, you will see most of us in yellow or golden color today, because golden color is symbolic of childhood cancer awareness. It represents the courage and resilience with which our tiny warriors, they face the cancer and beat it. So warm welcome to everybody. Before we go on with the first session, the speaker session, I would like to just briefly go through. We are very honored to be mentored by such esteemed physicians across the country who are mentors for patient support group, like Dr. Tapan Saikia, Dr. Naveen Khatri, and Dr. Revati Raj ma'am. I think they need no introduction. And also, apart from me, there are other members of patient support group, like Dr. Venkatesh. Can we go on to the next? Yeah. So Dr. Venkatesh Ekbote, me, myself, Miss Ria, who is the psycho-oncologist, and Miss Suman, who is the nursing in charge at BMT unit at ACTREC. We are, go on to the next slide, please. Yeah. So we are, I think it's an absolute pleasure and privilege for all of us today to have Dr. Shripad Banavali sir with us to address this session as a speaker. Sir is one of the pioneers of pediatric oncology in the country, and sir is also currently the president of IAP PHO chapter. Welcome, sir. So, sir
Thank
is
you, thank you.
chairman, PHO, and academic director at Tata Memorial Center, Mumbai. Over to you, sir.
Thank you, Silky. And when people like you, Revati, are sitting there, I to talk on BMT looks really odd. But I'll speak from the clinician side, maybe because I definitely treat a lot of children with ALL. But if they require transplant, I send it to Revati or Silky or to Naveen or some other people. So I will just introduce the subject. I think you all have a panel discussion and all later. Unfortunately, today, I have another meeting going on downstairs. The uh, TICON meeting, the teenagers and young adult oncology meeting is going on here in Ahmedabad, and I'm attending that. So I've taken their permission and come out to give this talk. So thank you, everyone. If we can give me permission to share my screen, can I?
Yes, sir, you can. You can.
Oh, great. Okay, I can't. Can you see the screen?
Yes, sir. But we are not able to see the PPT.
Yeah, I'll just open it. Can you see
Okay.
it now?
Yeah, the screen we can see it
Great.
now.
Great. So thank you very much. And I was a little confused about my role. So till yesterday, I thought it's a panel discussion. So I was, but when I told, and I was traveling yesterday also, so I put some slides just to introduce the subject, and maybe if there is any questions, either me or later in the panel, we can discuss those. But very importantly, all of us who deal with children with ALL, we are very, very happy And proud to say that childhood acute lymphoblastic leukemia was one of the first cancers to have such a high cure rate. And as you can see here from this, just yeah. So basically, you can see till some years back, hardly any patient with ALL used to be cured. But over the years, slowly and steadily, you can see now more than 90% of the children with cancer are cured. But this you can see here, this is a 2000 to 2005 data. And this is data, all this data is from St. Jude's Children's Hospital in USA. But that same reflects at other centers also. But very importantly, I put this slide again because you saw that 2000 to 2007 we had this 91% outcome, but you see now even from 2000 to 2017 that has remained the same. So what I want to say is one side we are happy that we have gone from 0 to 90 plus percent, but the other side, with the present treatment, with the chemotherapy, I think we can only expect this much, and it cannot be improved just with the use of chemotherapy and the existing therapy. And we are looking at newer therapies if you have to cure more children with ALL. And that's why what lessons we have learned over the years is that further intensification with chemotherapy approach is likely to be unhelpful. The current goal of treatment is limiting the toxicity in all risk group basically, and preserving the outcomes in non-high risk patients and improving the outcomes in high risk patients by basically giving treatment that will be least toxic to the children, because most of the children with ALL will be long term survivors and they are going to be alive for next 50, 60, 70, 80, 90 years, and they have to be useful to the society. So we are decreasing the toxicities. The newer things, targeted therapies have come into oncology, but more so in adult oncology, in pediatric oncology, and especially in childhood acute lymphoblastic leukemia. The role of targeted therapy is very limited, and immunotherapy will play a bigger role. We'll talk about it in this thing before we go to transplants. So if you can see here, patients with Ph positive, this is a subgroup of ALL which was very high risk, and hardly 10-20% of the children used to be cured of the disease. But now with the use of our targeted therapy, imatinib, which is a drug which is used in Ph positive ALL, and there's the first generation, and then I'll show you subsequent generation also. But if you see with the use of imatinib, the targeted therapy, the outcome of children with ALL, Ph positive ALL has improved a lot. And now with the third generation, for example, tyrosine kinase inhibitors like this here, ponatinib, along with the use of antibody treatment, the immune treatment that I told you, I'll talk about it later, but Blina is a antibody treatment. If you combine that with minimum chemotherapy, not aggressive chemotherapy at all, with just minimum chemotherapy and use of tyrosine kinase inhibitors and antibodies, you can see the outcome is nearly 95, more than 95%. So things are changing and they're changing for the better, but this is for certain subgroup. Now you have to understand that unlike our chemotherapy, which we gave the same treatment for all patients, in targeted therapies, in immunotherapies, the child has to be eligible to receive that treatment, and unless it is there, we do not use that therapy. So this is for Ph positive ALL, and this is what I told you, the immunotherapy that was targeted. Now this is targeted immunotherapy. If you see here, we have a lot of antibodies that we can use in patients with ALL, both in T-ALL and in B-ALL, but it is used mostly in B lineage ALL. And as I'll just show you two antibodies that have really helped us a lot in the clinic. One is the anti-CD22. So, the leukemic cells express certain receptors, and one of them is the CD22. Like you have different CD2 receptor, and then basically it will kill that cell. So this is one antibody, but the other one which is really in use now more and more is the anti-CD19 antibody. That this is a bispecific antibody. That means this antibody on one side it expresses the CD19 and the other side it expresses CD3. Now CD19 is an antibody expressed by the leukemic cell and CD3 is expressed by the T lymphocyte or the immune cells which are act against the cancer cells. So one side it will get attached to the T cell and it will bring that T cell nearer to the leukemic cell which is expressing CD19 and then that will kill this cell. So this is bispecific we call antibody blinatumomab, which is in short we call blina. You all must have heard it being talked many times during the when the patients are being counseled or the parents are being counseled either at the time of initial treatment or at the time of relapse. So these are two antibodies which will be used very much in the clinic. And you can see here basically another very bad. I showed you one bad type of ALL which we call the pH positive ALL, and how using this antibody and the basically antibody along with the targeted therapy, we can have now more than 95% control or cure of the disease. Similarly, there's a other type of ALL which is very high risk, what we call, which is the infant ALL. That means children less than 1 year of age. When they develop this ALL, it is called infant ALL, and that is a high risk ALL. And see, you can see most of the time the event-free survival was less than 50%, but with the use of minimum chemotherapy and this antibody, the Blina bispecific antibody, you can see that the outcome of 3 year overall survival has gone up to more than 80%. So definitely this helps in certain high risk patients, in certain subset of patients, and we are taking this help to improve the outcomes. Now, why I'm telling you all this? The another one which again is the same. You heard about the antibodies. The other thing is the live drug. That means we take out the patient's T cells and make them express this CD19 antibody, I mean receptor, and then infuse those T cells inside the patient. This thing, so that is called chimeric antigen receptor T cells or the CAR T cells. And again, these are live drugs. That means they not only go and kill the cell once, but when they kill the leukemic cells, they again regrow and expand in the body and keep on expanding and remain in the body for a longer time, so that any leukemic cell which is there in the body, it can kill those cells. So why I'm telling you all this is that because with the use of this, targeted therapies, antibody therapies, CAR T cell therapies, again, this is just to show that this was even developed for the first time in India in our Tata Memorial Hospital along with IIT, and that this is Dr. Raul Purwa and Dr. Gaurav Narula from our hospital with the help of others from NIH and all developed this CAR T cell for the first time in India, and this is already in use in adults and still explode in children. So why again I'm showing you all this data is that you can see, till these newer therapies were available, the number of bone marrow transplants being done in ALL was increasing. You can see till 2002, 2003, this number was increasing, but slowly over the years now, you can see that the number of children with ALL getting transplant is decreasing. You can see all other things. This is really remain the same or constant, but the transplants in children with ALL is slowly decreasing, and this is mainly because now we have so many other treatments available to us, which has decreased the need to do transplantation in children with ALL. So you have to keep that in mind, and that is why I showed you all the other treatments that are available with us in our armamentarium that has helped improve the outcome of children with ALL. So, why we still require the bone marrow transplant, and who are the patient? That is the topic I've been given, bone marrow transplantation in ALL. Until some years back, we used to give the treatment or the what we call induction chemotherapy to the children with ALL, and then again repeat a bone marrow after that and look under the microscope. If there were less than 5 cells, 5 blasts in the marrow, we used to call that the child has achieved remission. But you can see here 5% blast is somewhere here. That means if the child has less than 5% blast in the marrow, the child is here. That means they may still have so many leukemic cells and still the child will be called to be in remission. Whereas now when we do a test called minimal residual disease estimation or the MRD estimation, that when we do, depending on which type of test we use, that is either the flow cytometry or the molecular testing, RT-PCR, or the genomics, we can see that you can see if the patient is in remission, whether it is here or it is here or it is here or even here. So here they all are called in morphological remission, but depending on how deep the remission is, the patient will be either here, or even here when he is already called in morphological remission. So this has helped us to identify or risk stratify our patients much better. That means you can clearly see here if the patient is here in remission, but here you can see the cells can grow back and cause what we call relapse. If they are here, again they may come up and then cause relapse. Here they may cause a late relapse, but if they are somewhere down here, then there's a high chance that this patient will be cured of the ALL. And now the test that we do, what we call MRD estimation, either by flow cytometry or by molecular testing, we can tell whether the patient is in deep remission or the MRD negativity. So that is here. And why this is important, actually, again, it will show. So what ultimately is MRD estimation? When you diagnose a child to have ALL, we give them induction chemotherapy or chemotherapy is given. The aim is to kill all the cancer cells, and then once the cancer cells are killed, the normal cells will come up. So the aim is to give the to kill all the leukemic cells. So what is MRD is that if you have there are certain leukemic cells which will get killed with the chemotherapy and certain leukemic cells which will be resistant to the therapy. So if the leukemic cells are resistant to the therapy, then we will have residual disease, that is MRD positivity. But if the leukemic cells are sensitive to the treatment that you are giving, then it will kill all the leukemic cells and the patient will be in MRD negative. That means they will be in MRD remission. And this is the importance here. So we do this at various time points. The first time point is around day 33 at the end of induction. And if the second time point is at the end of consolidation, that is day 66 to 70. So what is the significance? You can see here if the patient's MRD is negative at time point 1, that is post induction, these are the patients, nearly all the patients will be doing well or will have a cure rate of more than 95% here. But if the patient was positive at the end of induction but became negative at the end of consolidation, that is at the second time point on day 66, some of them will do, most of them will do well, but some of them will not do well. So they go into the intermediate risk around 75% cure rate. But if the patient or the child was MRD positive at the end of induction and continues to be MRD positive at the end of consolidation also, that is time point 2, then they are called high risk, and these are the patients which definitely will require transplant. Along with there are other indications also, but one of the indications for doing transplant in first time only is that patients who have high risk group, that means patients who after the end of consolidation also still continues to harbor minimal residual disease, and they are the ones who will require transplant. Whereas patients who are in this group will do so well that most of them will not require any transplant. And here there are certain patients, we'll talk about it, who may require transplant, and many of them would not require transplant. So this has helped us risk stratify our patients better. That means to identify who are the patients will require bone marrow transplantation. We'll talk about it later, but this is a very, very sensitive way to identify patients with ALL who will transplantation. There are many papers actually. You'll see a lot of data in this thing. Again, I had a very short time to prepare this, so I just took out one of the review papers. But there are many of those which will tell you who are the patients who should be transplanted, when they should be transplanted, how they will be transplanted. But like I told you, I'm just going to give you a brief overview of this subject. And I think there are Revati, Silki Jain who do a lot of transplants, so they may talk to you in detail in the panel discussion later. But who are the patients who require to be transplanted at the time of initial diagnosis only? That means you diagnose a newly diagnosed child with ALL. There are certain patients who we call to have a high risk of relapse. Now, this high risk, low risk is high risk to be relapsed, to get relapsed, or low risk is the low risk to get relapsed and high risk to get cured. So high indication to get cured. So basically, we there are various groups who have given various indications. But if you take just one of these, it will tell you there are certain risk groups. If you know, in children with ALL, when we do a bone marrow, we not only do the morphology, we also do the flow cytometry to see the antigens expressed by the leukemic cell, but we also do certain cytogenetic and molecular studies to identify certain risk groups which are high risk and they require more aggressive treatment or a different type of treatment. And one of them is the TCF3 HLF1 or the T. Basically, these are basically patients uh, with molecular this thing who have high risk of relapse. This is called 1719. Now, very, very importantly, these are not a big group. These like form less than 0.5%. So if you have 200 patients with a childhood ALL, one of those will have this TCF, HLF, or the T1719 translocation. But if the child has this translocation, he or she will require transplant to get cured. And even with transplant, they were not getting cured. But now, with the use of antibody therapy and transplant, many of these children will be cured. So we have to know who are the patients who will require transplant. Like I told you, 90% or 85%, or I would say with 90% of the children at the initial diagnosis will not require transplant, and only a small proportion of patients require transplant. So we have to identify those at the beginning only. So this is one is the TCF3 HLF or the T1719 translocation. Then other translocation with like I told you, the infantile ALL. This is if the child is less than 1 year and is diagnosed with ALL and has this KIT MT2A gene rearranged, which is called the MLL gene. If that is rearranged, and if the child is less than 6 months, has a very high WBC count, then that child will require transplant to get cured. There's a small group of hypodiploidy who, again, less than 5% of the patient, but they may be benefited of by transplant, but there is data for and against for this. So we have to really go deep into the indication, really find out that the child requires transplant or not, and whether if we do the transplant, the child will be benefited by that. So, like I told you, we look at various molecular markers or the prognostic markers. So, this is one gene, KMT2A is the second gene, hypodiploidy. Then there's another thing called IKZF 1 plus. So that's again, you don't have to understand the exact terminology, but by doing this type of molecular studies, we can identify again subgroup of patients who may not do well with chemotherapy. Now, again, whether they are high risk or low risk depends on what treatment that we give and whether that treatment is effective in the patient. For example, I showed you if the patient was patient with Ph positive ALL, once upon a time, all these patients require transplantation to get cured. But after the use of the targeted therapy, the imatinib, less than 20% of those will require transplant. But now with the use of antibody plus that is the blinatumomab plus the targeted therapy, either dasatinib or imatinib, less than 5% of those will require transplant. So as our treatment gets improved or we give the right treatment, the better the chances of getting cured with treatment alone, and less the chances for need of bone marrow transplant to get cured of their disease. And again, so in this group now, the most important role that has been played is the use of MRD. So if the MRD is negative at time point 1, they don't require transplant at all. If it is negative at time point 1 and positive at time point 2, then a certain positive at time point 1 and negative at time point 2, only a small subset of those patients will require transplant. But if the patient is having MRD positive at time point 1 as well as time point 2, most of them will require transplant to get cured. So these are the things that we use in for the initial part. And same way, actually, patient who is doing well is was in remission, doing well for years or months, but then had a relapse. Now, at that time, that is what we call clinical remission too. That means if the child has a relapse ALL, we put them back in remission. And then who are the patients who require transplant? Again, those who have early relapse, that means the disease comes back within 3 years of diagnosis, or if there's a late relapse but the MRD is positive, then these are the patients who will require transplant. Any TALL patients, patient with, there are two types of ALL, B type and T type in a broader sense. And T cell ALL, if the patient basically has a relapse, all these patients, irrespective of when the relapse has occurred or whether MRD is negative post treatment and all, now most of these patients will be treated with bone marrow transplant. So this is at the time point 2, and this is just to show you that for children with KMT2A, that is the infantile ALLs, were being treated with chemotherapy alone. But if you give them chemotherapy and then transplant them, they have done well. But now with the use of the monoclonal antibody, the blinatumomab, maybe less and less patients with this group will be transplanted. So again, stressing that the indications for transplant in ALL is childhood ALL especially is coming down, and the numbers are decreasing, and the specifications are also changing. So just a slide or two of what type of transplants there are. As you all know, there are various types of transplant. One is the matched related transplant donor. That means the donor is a sibling, brother or a sister who is completely matched. But that in today's era where you have one child only or two childs, very, very rarely we get match related sibling donor. So the other one is the matched unrelated donor. That means not a sibling, but in the bone marrow registries that we have, there may be a match, and if there is a match, we may use that donor also. But more importantly, now more and more we are doing what we call the haploidentical. That means there are no match sibling, but everyone has a father and mother or a brother and sister also who may get half match. That means only half the genes are HLA typing is matching. Even they are being used now more and more as the donors. And cord blood, though we talk about it, but in India very rarely we do cord blood, and this is nearly given up in the transplant community, at least at present age, because haplo has become so common to do a haplo transplant as compared to the other transplants. And there are various conditioning regimens. I think they may have it in panel discussion, but I don't want to bombard you with what. But we give certain medicines to the child before taking up for transplant, so that to kill all the bad cells as well as create a space for the stem cells which are given from outside to grow. And in ALL, we also give most of the time total body radiation, because that has shown to improve the outcomes or decrease the relapses in children with ALL. And there sometimes we also, in especially in haplo, we also decrease the bad cells. That means the TCR alpha beta cells, positive cells, or the CD19 positive, we deplete them, or T cell depleted marrow, so that basically it decreases the graft versus host disease, as well as basically decreases the chances of relapse. So these are some of the things that we do to before transplant. So just to end on a philosophical note, we over the years now our definition of high risk, low risk, good disease, bad disease has changed. So this is just something to think about. We always tell that the doctors tell that there are certain diseases that are incurable. Do you know what an incurable disease is? It is the one that doctors don't know anything about. The disease has no objection to be cured at all. So, what is important is that once we know how to treat or we get better drugs to treat that particular disease, the outcomes improve as it is. And many of the disease, even subgroups of childhood ALL, which were bad at one time, are now highly curable with the present treatment that we have. So, I think that's what I had to say. And maybe if you have questions now, or maybe at the end of panel discussion, you can have that.
Thank you so much, sir, for that enlightening talk and for letting us and our audience know that it's not all the patients with ALL need transplant. The primary treatment is chemotherapy, and most of them respond to it. But even if the disease is difficult, I think what is important for them to understand is that we don't need to lose hope. And there are a lot of options out there, thanks to the scientific advances, including bone marrow transplant, which can provide the long-term cure in difficult disease as well. Thank you so much, sir. So
Thank you. Thank you. So,
we will
if you
move.
don't mind, I'll take your leave because I have to attend that meeting down.
Sure, sir.
Thank
We
you so
understand.
much,
Thank
Dr.
you.
Srivak, for joining us today. Thank you very much. We're
Thank
very
you. Thank you.
grateful.
Thank you. All the best. Thank you, Revati, also. Thank you, Dharani.
Thank you, sir.
So we will move ahead with the panel discussion. So the panel discussion is going to be around radiotherapy in pediatric transplants. So we have a moderator with us. Welcome, Dr. Dharani. Dr. Dharani is consultant pediatric hemato-oncologist at Rela Institute and Medical Center, Chennai. And we have esteemed panelists as Dr. Rimpa Basu Achari. She is senior consultant and chair in the Department of Radiation Oncology at Tata Medical Center, Kolkata. We have Sister Viveka with us. She is clinical nurse lead Apollo Specialty Hospital at Chennai. We also have Miss Lakshmi with us. She is a psycho-oncologist at Narayana Health, Bangalore. And sir unfortunately couldn't continue, but we were really grateful to listen to sir earlier. So, yeah, over to you, Dr. Dharani.
Thank you. Thanks a lot, Silky. Thanks to Reti ma'am and the entire team of ISBMC um, group for giving us this opportunity. Uh, yeah. So, welcome to the panelists. So, the agenda given for today is to discuss on total body irradiation as a part of conditioning for the transplants for acute lymphoblastic leukemia. So we all know that total body irradiation is a backbone for the ALL bone marrow transplants. As we know that conditioning is always one of the difficult parts of transplant, and we are worried about the toxicities that the children have to face, and the parents will be equally worried about the toxicities that they face immediate and late. So total body radiation has similar effects compared to the conditioning chemotherapy drugs, but the logistics and the certain aspects are different. So we will have a discussion on that. As Banavali sir could not join today and Reti ma'am has thankfully offered, I would direct the questions to ma'am in between. Thank you, ma'am. So let us start with the questions. So the first question is to Dr. Rimpa. Ma'am, could you please explain what is total body irradiation and how is it delivered to the patient?
Yeah, thank you, Dr. Dharani, and good afternoon, ladies and gentlemen, and all our viewers. So, is it possible for me to share my screen just to show a photograph to give an overall impression? If not, it's okay, I will describe.
Ma'am, please go ahead.
Okay. Go ahead in describing or sharing.
Ma'am, sharing.
Okay. So I think my screen is visible.
Yes, yes.
And for all of us there, I will see. Okay. So total body irradiation, as the name itself signifies, is irradiating the whole body, and that means everything. because leukemic cells can be really nasty and they can hide in many places where chemotherapy may not be able to reach. However, the scenario is changing with immune therapy, like Banavali sir and Dharani mentioned. So this is the kind of setup, this is a child. These photographs are with permission, and this is from our own published material. And uh, total body radiation, or radiation itself, is a multi-step process, where before they come to you, your hematology colleagues would have already made a decision for transplant and would have primed you that you would have to go with your child or with your teen or whatever, whoever the patient in concern is, to the radiation oncology team, where our team or radiation oncology team again is a multidisciplinary team comprising of our lead nurses for TBI, our lead radiographers, who are staff who handle these very large machines called linear accelerators, and this is how a room of it looks like. And even getting onto this actual playing field for delivering whole body radiation, any children undergo steps of measurement after reassuring them that the overall treatment is completely painless. They may feel scared in a large room staying alone, but we reassure these children that, and their families, by showing the zones where the child would visit in future. And we have a team. What has already always helped us and all organizations across the country is orienting the family and the child to staff and environment. And we take these children through the steps of measurements. So, like a tailoring shop, a lot of measurements, a few simple scans without contrast. And then in the background, before the main procedure, our staff and us, we will be calculating doses at various points in the body. And this is how an actual treatment looks like. So this is a linear accelerator. A child would have come down from the bone marrow transplant unit, and various ways to ensure adequate dose distribution right from the head to the foot. And for all our children and patients who undergo such complex total body radiation procedures, we have a very simple, comfortable position for the child or the patient, and they are monitored with, you can see these wires, these are actually backup monitors, and you can see little small devices placed all along the child's body. So these monitor the doses which are delivered by this machine to various parts of the body. You will also notice, although it is I should have zoomed up maybe, that there are certain very critical areas like the lung, the brain, liver, kidney, etc., which, although they need radiation therapy, but they need some protection. And for our service, we use brass protection devices which go onto this machine head, and we monitor doses below that, so that we don't cause any organ toxicity. Like Dr. Banavali sir very rightly said, the goal of the entire, the hematology team with all its components is now to improve not only outcomes for the children, but quality of survival. That what is it that is causing more difficulty for these children? And he rightly said, it is definitely not more chemotherapy, but it is also a smart combination of safe delivery of treatment, incorporation of immune therapy, and of course, various techniques of radiation therapy to keep our children safe. I think that is how radiation therapy is, that is what total body radiation is, and this is how it is delivered for most children. And for very small children, I think we have a little conversation about sedation, etc. later. So Dr. Dharani, handing over back to you, and I will stop sharing my screen.
Thank you, Rimpa. So she has answered most of the questions that are going to follow anyway. So, so now we know that we are going to irradiate the whole body to wipe off the stem cells from the patients so that the patient can accept new stem cells. We need to know which all conditions where we use the total body radiation, and is chemotherapy better than total body radiation? Revati ma'am, do you want to answer?
Thank you, Dharani. So, Dr. Banavali had given a big introduction to what we're talking about. in children with ALL, the majority of them we try to cure with chemotherapy. We used transplantation for only the ones that have been very difficult to eradicate with chemotherapy or the ones for whom the disease has relapsed. In fact, as Sir had mentioned, nowadays the number of children we transplant is coming down because we have these newer targeted therapy and immunotherapy. For example, we used to transplant a lot of children who had this high risk leukemia termed Philadelphia chromosome positive leukemia, PH positive. So in the 1990s, the cure rates were 5%. But just by adding a drug called dasatinib or imatinib, now the cure rates are so much higher that hardly we transplant. Most of these children receive chemotherapy along with targeted drugs. Blinatumomab, inotuzumab, they all have reduced the number of children that go to BMT. But clearly, there was a huge trial worldwide, especially in the European cities, and the group trial called the Forum trial proved without a doubt that in children with ALL, especially relapsed ALL, total body radiotherapy is superior to chemotherapy. In all other conditions other than ALL, we prefer to use chemotherapy over total body radiotherapy. So ALL is one condition where the preference is total body radiotherapy, and we split the doses over 8 days so that we can reduce the long-term side effects. But if we don't use radiotherapy and we use chemotherapy, the relapse rates are higher. Whereas in other conditions for which we transplant, we use various combinations chemotherapy, and we worry about exposing little children to radiotherapy because of long-term side effects, which I'm sure Dr. Rimpa can highlight when she's doing her talk. But all of these decisions are clearly it's to balance regimen related toxicity and cure. We want to cure the child, but we want intact survival. So we do a risk benefit analysis and see which is better for that particular child and make a decision.
Thank you, ma'am. So now we go to the next question. Is TBI painful? So all the parents ask this, is chemotherapy painful? Will my child bear it? So Dr. Rimpa has already said it's not. Ms. Lakshmi, I would like to ask you, it is seen that parents are often apprehensive. So how do you counsel the parents to relieve their anxiety?
Thank you, Dr. Dharani. So initially, when we meet most of the parents of our children, there's a sense of fear and association with danger that we see when the whole word of radiotherapy comes into the picture. So one of our first steps there would be to validate their thoughts or feelings about radiation rather than dismissing them, and then later in providing them with information regarding what radiation looks like. Like Dr. Rimpa mentioned, it is not painful, and steps of radiation, or what are doses, or what is the setting that it happens in, what does the machine look like. So information about all of this is provided at a second level after initially validating the fact that they are worried about it. A lot of our parents feel much better when somebody is validating those feelings rather than immediately dismissing them with the educative part of it. Another thing would be to definitely break down the information into simple and easy to understand language, and reassuring them that this is not an experimental treatment. This is something that has been planned. Doses have been calculated by our medical team, and sort of sitting with the parents with the whole uh, schedule of radiation that is being planned is something that would help. Another thing, I think, again, like Dr. Rimpa mentioned, something we do a lot for our children is show them educational videos or like child friendly videos of other children getting radiotherapy, or having a mock trial where they go into the room and they are in the machine, but there's no actual radiation that is provided, just so that they can get comfortable with the setting. And sometimes we do also get creative for some of our children where they want their mask to be painted, or all the gear that is used in the radiotherapy process. So we've had children who've wanted to paint it as a Hulk mask so that they feel like a superhero. So sometimes small things like this helps in aiding concerns parents or children have at a procedural level. It helps in making it as a sort of simpler thing in their head rather than a very dangerous and fear evoking situation. And again, we do accompany our children up until the radiation room, and we're right there outside with the parents. So, sort of providing that sense and that space for them that we're not here just for your medical needs, but if you do have concerns regarding the whole procedure, our team is here to sort of listen to your concerns and try to address them at whatever levels possible. So, I think that is how our approach would be to counseling the parents in terms of concerns they have with radiation.
Thank you, Ms. Lakshmi. So, yeah, so their anxiety is acceptable. So we need to explain them and get them know the facts is the right approach, as you rightly said. So, Ms. Viveka, can I ask you, how do you care for a child who is going through a total body radiation? So, what precautions do you take? Any particular precautions for these children for skincare?
Thank you, Dr. Dharani. That's a really important points you have raised. When the child is undergoing total body irradiations, require the close monitoring and medical precautions and family support is required. On the daily basis, we carefully assess the children of general conditions as well as monitor the vital signs before and after radiation session is completed. And also, this children is receiving a high dose of chemotherapy in the conditioning regimen. So we need to monitor the yearly side effects like mucositis, vomiting, and fatigue. And the nurse should be maintain the state intake output chart and also ensure the adequate hydration has been received or not. And the renal production is very important. And follow your infection control practice as well as your neutropenic precautions too. Why the skin care is crucial during the TBI, the radiation sensitivity. So the TBAs make skin fragile to prone to get the redness and skin peeling and dryness often. When the skin is damaged, it's the entry point of bacteria and fungi and immunocompromised children. So we need to take a special protections for these children after receiving each session of radiation. With the lukewarm water, we have to give the sponge bath for children and keep moisturized and wear the loosened clothes and avoid the tightened clothes when the skin is irritated area, as well as teach the parents if they found any skin changes which has happened to the child should be reported yearly. This how we need to take care of the children when the child is going for the total body radiation. Thank you.
Thank you, Vikasta. So, even while they pass tools and we clean the genital area, so all these steps need meticulous precautions. Though the mother might have been doing it for years, now when they receive chemo and radiation, they have to be more cautious. So, there comes the significant role of nursing, as you rightly said. So, Dr. Rimpa, can I ask you, is there any specific preparation needed for children when compared to adults? And what is your comment on sedation for children needing TBA?
Yeah, thank you, Dr. Dharani. I think the most important points are being discussed about skin care is again, giving the right information. That is very important that usually there isn't any scrubbing. However, and the other point that came to my mind when she was talking of skincare is we always request as a part of the policy to see that the nail care is adequate. Because what I wanted to mention is apart from skin that breaks down later, of course, these are reversible problems. Children have a lot of itching to begin with, because of the cytokine release with early fractions of radiation therapy. And because they are children, they often land up scratching or attending to their problems. And therefore, nail care is important. And that has helped us in the past. And all of you, I'm sure. So for specific preparations in children, what we have noticed is orienting them and reassuring parents and children about having no fear has always helped us. Adults are more they are grown up, they understand what is being told, but with children, showing them, taking them around, more than once, reassuring them, and tagging a specified member of the team has always helped us, be it social support, be it a research nurse or a clinical service nurse has helped us. And for specific preparation, we've told children to, make them very aware that they can, because these rooms have bilateral slave monitors that can monitor their voice and their images inside. So if they have any problem, they can just call out for us or for their mother, and we will interrupt treatment and go in. I think that's a preparation. And for very young children, it is needless to mention that they would need sedation. And sedation in non-operating room areas will have its own policies so that, we can monitor them well. And an essential thing there is we use more than one slave monitor for multiple checks for these small children, because it's very complex treatment. We are having to monitor the equipment as well as the child. And I think, but once the team gets used to it, and there are written policies which staff follow with special training for staff, apart from reassuring mothers and of course caregivers, it is a simple way. And what has always helped us is we keep the caregiver, most often the mother, in every step when we take the child or the family through treatment, except when the actual treatment is being delivered inside. So that gives parents and caregivers a lot of assurance and reassurance. Thank you.
Yeah, thank you for bringing out very valid points. So explaining them, as you said, and preparing them, uh, giving them gives reassurances, making sure they are heard and they are constantly monitored, and priming the children for a couple of days prior to they start the radiation, that has actually brought down the need for sedation in most of these kids. And invariably, they come out with a toy or a chocolate all the times after the radiation things. And the beautiful wall pictures and your seats also make them more comfortable.
That's right.
For sure. So that we go to the next question, that is for Revati ma'am. Ma'am, could you highlight on the immediate and late side effects of total body radiation? What should be known? Can we move the slide, please?
So yeah, I think Lakshmi beautifully pointed out how to prepare families is by giving information, and definitely there are immediate side effects and late side effects, and one of the most important immediate side effect is nausea and vomiting. So before sending the child for the radiotherapy, we make sure we've given them medicines to prevent vomiting. We use steroids, dexamethasone, because it's good in reducing inflammation. And sometimes these children need to have two anesthesias, so they have a lot more nausea, vomiting, because they've not eaten. Morning they have one sedation, evening they have one sedation. So nausea and vomiting is an important part of the immediate side effect. And sometimes the children get something we call parotitis. There is a swelling of the parotid gland. Sometimes the skin gets very sensitive, and especially we have to watch their perianal area. With radiotherapy, the side effects, which are long term, are always dependent on how much you give. So in children, we are particularly trying to reduce the dose of radiotherapy. Previously, we used to use 14.4 gray. Now we've cut it down to 12 gray. And even that, we try to give it over 8 fractions. So not give all the 12 gray in one sitting, but give it over 8 fraction. And now there are ongoing trials to reduce it down to 8 gray so that the long-term side effects can be reduced. And mostly we worry about their growth. We worry about their hormone production. So especially thyroid, hypothyroidism is a common occurrence after whole body radiotherapy, and they can get cataracts quite early. So these are some things for which we watch out for. And because in our body, the most sensitive organ to radiotherapy is the ovaries, the ovaries, and the testis and the hormone producing glands for fertility. So these can be affected due to the radiotherapy, and this is something that need follow up, and we counsel families upfront that we will watch for these side effects.
Thank you. So the next question has already been answered by ma'am, the risk of peritonitis. So I skipped that for want of time. So Ms. Viveka, can you please tell us about the specific diet precautions that you give to the parents when they are on total body, the children are on radiation or chemotherapy?
Um,
You are muted. Yeah.
Oh, sorry. Nutritional wise, we need to give for neutropenic diet. Neutropenic diet is nothing but it's a double cooked, well boiled diet. It's low microbial and high calorie and high protein diets. And also, we should avoid the raw food cells. So, when the mucositis is developed, we have to encourage the child to take a soft, bland diet and frequent adequate fluid intake, as well as the oral integrity care is very, very important. It can be considered the pain management starting in pain medications, as well as IV nutrition also we can be considered when the child is on neutropenic. Thank you.
Thank you. So the neutropenic diet is very important. We'll go a bit faster. So Ms. Lakshmi, could you highlight on the psychological or cognitive impact in children who have had TBI or a cranial radiation?
Some children who undergo a TBI or cranial radiation may experience changes in thinking and learning. This can include slower processing, difficulties with attention or organization, memory challenges, etc. But it is important to stress that this does not happen in every child. And even when it does occur, it can be addressed effectively with support. So, something that is very crucial here is having baseline neurocognitive assessments before treatment starts and following that up at a yearly basis, and including cognitive rehabilitation in terms of academic progress or to strengthen their skills when they are post treatment. Treatment can also affect mood and behavior in terms of heightened feelings of anxiety or irritability or social withdrawal and social engagement concerns. Again, these are all things that are inevitable, that are not inevitable, but early guidance and coping skills training, which is something we actively work with all of our children undergoing TBI for, that helps them maintain confidence and social engagement. So again, early guidance and intervention from beginning of treatment is something that proves to be very effective. And again, long-term follow-up becomes key here. Regular neurocognitive monitoring, ideally at a 1 year mark, is done, and anticipatory guidance in terms of what are signs and symptoms to look for, what are interventions and how can they be detected, and how can we as a multidisciplinary team with the medical team, the psycho-oncology team, as well as school and academic team can all work together to sort of provide that uh, uh, setting for children to thrive and enhance their skills. So again, long-term follow-up and neurocognitive assessments at a baseline and yearly time marks make the big difference here.
So rightly said, the follow-up clinics and the assessments are very important. So, Dr. Jimpa, can you quickly tell us about TMI, which is expected to reduce the side effects of
Yes.
TBI?
I think before answering that question, I'll just make a disclaimer that we are discussing all the side effects of radiation, not to scare everybody who's in the audience, but just to reiterate and underscore that it is information that is being given out, and the benefits of the use of radiation therapy for these children who need transplant for their high-risk leukemias far outweigh the disadvantages of TBI. And therefore, be not scared. I mean, if techniques are appropriately used, your child or your loved one will actually be, there would be a high chance of cure at some cost. So the entire community is looking at how that cost can be brought down. Yes, there are methods and techniques to further complicate TBI delivery procedures and in order to reduce that cost, but the jury is still out because in those high-end techniques it holds a lot of promise, and theoretically we understand that the side effects may be marginally lower, but the cost is again for that is very resource intensive. There is no level 1 evidence of comparing one against the other. It is, of course, based on equipment availability and team expertise. And what is most important in total marrow radiation is how to manage physiological motion for when you're radiating the ribs, etc. And the dose rate of radiotherapy, which is known to have a detrimental effect on lung and end organs if the dose rate is high. So, but there are methods to address, yes. If it's a yes and no answer, yes, there are methods, but very standard, conventional, time-tested, safe radiotherapy techniques, which can be done in most hospitals which offer marrow transplantation as cure, remains the standard of care.
very painful for them, so they need sedations for when they're doing a procedure to this inserting the NG tube also. So avoiding that, electively we can insert the NG tube insertions, and also we can avoid the repeated IV nutrition, so that CLABSI reductions also will be coming down. And also we can ensure them to give for the on-time medications and ensuring a continuous feeding for these children too. Thank you.
Thank you. Completely agree. Only that the very young infants rarely get TBI, but still the other conditioning also demands this NG2. The last question to Revati ma'am. Any contraindications for a parent to stay with children undergoing TBI?
Yeah,
So
thanks,
because
Dharani. So, during the actual radiotherapy, the child receives the radiotherapy in the radiation room, and obviously, attenders are not allowed inside. But before they go into the treatment room and after and throughout, the family can stay with the child, and we do encourage the parent, especially the mothers, to be part of the treatment, because these are all difficult times for the child. They have to be inside a room and inside a very confined area, as Rimpa had pointed out. So before and after, and sometimes during radiation, we have facilities where the mother can keep talking to the child through a speaker system, or they can have their favorite songs or nursery rhymes played all through, and they can keep talking to the child. So, if they are very anxious, we also sedate them during the procedure, but to be with the child during before and after the treatment is not at all a contraindication.
thank you, ma'am. Thank you for all the panelists. I hope we have addressed most of the important questions that comes to the parents' mind. As Dr. Rimpas rightly pointed out, this is a difficult disease to treat with, so we need to have a difficult treatment as well. But the children, with our support, with our understanding and a proper support, they definitely come out of it very bravely, and they do teach us that nothing is impossible. So Thank you, everyone, for this opportunity. I hand over the session back to Silky. Thank you.
Thank you so much. I would like to invite Revati ma'am to please deliver vote of thanks, ma'am. And thank you so much for joining us for the panel discussion at the last moment.
So, thank you, and Silky and all of the panel members and Dr. Banavali. We are indeed very grateful to him in the middle of his busy schedule, and he is the current president of the Indian Academy of Pediatrics IAPPHO chapter, and childhood cancers are curable, and no child should fight alone is the motto for this year's International Childhood Cancer theme. So, we want to make sure that the families are not alone in every possible way. You have seen that we've included so many people to treat one child, radiation oncologists, nursing, psychologists, NGOs, and people who support funding in addition to physician team and physicists. So there's a whole village of people that are needed to treat and cure one child. And increasingly, we are making sure that the child is surviving, and not just surviving, but we provide intact survival. And in the future, we'll be having more targeted therapy, more immunotherapy, and amazing new treatments like CAR T cell therapy. And the future is here in our country for our children. And that is actually thanks to a lot of research being conducted here within our country. I want to thank ISBMT for this opportunity, to Silky for beautifully conducting this session, and Dr. Rimpa, Viveka, Dr. Banavali, and Dr. Dharani for their contribution. And please remember to go gold for childhood cancer, and try and support any child or family who's going through cancer treatments, not just this month, but for a long time to come. It may be something simple, by just being a blood donor or a platelet donor. In whatever way, try and contribute to make sure that the one child has a chance of succeeding his illness, his or her illness. Thank you, and we'll meet again next month.
Thank you all.
Thank you, ma'am. Thank you, ma'am.
Thank you, ma'am. Thank you.
Thank you so much.